Good morning, good afternoon, good evening, depending upon which part of the world you are in. I want to welcome all of you to our continuing series on diet and non-communicable diseases as a part of the Harvard T.H. Chan School of Public Health India Research Center. My name is Viswanath. I'm a professor of population sciences here at the Dana-Farber Cancer Institute and professor of health communication at the Harvard School of Public Health. More relevant or germane, I am also the faculty director for the Harvard School of Public Health's India Research Center. India's demographic population continues to age, with more people moving into middle class and middle and older age groups. As a result, the burden of non-communicable diseases have also been increasing in India. Approximately, according to the latest data, there were almost 1.4 million new cancer cases that were recorded in the country. Over the same decade, in 2020s, cancer-related deaths have climbed by more than 30%. And as a population demography changes, and as the lifestyle factors change, particularly the transitions in lifestyle and diet, this demographic shift will likely intensify the burden of age-associated cancers and likely to amplify the cancer burden in the country, which means increasing mortality and morbidity will likely affect how we deliver healthcare. But we can't continue to treat people. It is possible that cancer can be prevented, as you will hear from our guest speakers today. And diet and nutrition are considered among the most significant modifiable risk factors for cancer. Research has consistently shown that eating red meat, processed foods, processed meats, alcohol, heavily salted food, refined carbohydrates are some of the diets that can contribute to the cancer burden. Obesity, driven largely by diet and sedentary lifestyles, is a major risk factor associated with at least 13 different types of cancer. And despite ongoing efforts to improve nutrition, dietary diversity remains a serious challenge across India. On the nutrition front, India has done some very interesting things. Particularly, we have had several flagship programs under Poshan Abhiyan targeting undernutrition. Many of these programs have been generally successful. There are some challenges with these programs, but by and large, the topic of undernutrition has been on the agenda for a long time now. However, when it comes to diet and obesity, in terms of its contribution to NCDs, has not been paid adequate or equal attention. And that's what we are trying to correct. So this webinar by the Harvard School of Public Health is a third in the series that will focus the link between dietary approaches and cancer prevention and control. We are inviting leading global and national experts who will share insights on existing research, public health interventions, and strategies to address this critical challenge. And we will cover a variety of topics to the extent possible. So what we will do today is I have invited 3 leading experts in the world who are focusing on different aspects of diet and cancer with an amazing record of contribution to the science. And the way we will work today is that I will call on each of them to talk a little bit about their work, and I have some questions for them. We'll follow that up with conversation. It will be conversational, and then open it up for audience questions. There are a number of participants, and I want to welcome all of you. If you have questions, for the speakers, please use the Q&A box, the question and answer box, rather than put them in the chat. And at the end, when we start taking your questions, my team will pass those questions on to me, and I'll try my best to cover as many questions as possible. So please feel free to enter your questions in the Q&A box. So let me again thank everyone for joining the call today in the audience, my three colleagues and my team at Harvard. So here we go. Let me welcome Dr. Heather Eliassen, who's a colleague of mine here at Harvard T.H. Chan School of Public Health. She's a professor of nutrition and epidemiology at the school and professor of medicine at Harvard Medical School. She's a co-PI of two major cohort studies, as we call them, the very famous Nurses Health Study and the Nurses Health Study 2, tracking more than 200,000 women over several decades. She also is a PI of several other cohorts. Her research focuses on breast cancer and the roles of diet, lifestyle, and underlying biology in risk and survival. Obviously, I'm not doing justice to her track record, but this should give you an idea of her expertise and her work. She will be followed by Dr. Shalini Singh. Excuse me for my apologies. I'm fighting a cold and fever, so I hope you can understand what I'm saying. Next is Dr. Shalini Singh. She's the director of ICMR, National Institute of Cancer Prevention and Research, in the Department of Health Research at the Ministry of Health and Family Welfare. Dr. Singh is also heads the Knowledge Hub on the Framework Convention on Tobacco Control in the country. And our current work focuses on promoting research for primary, secondary, and tertiary prevention of cancer, with an emphasis on oral, breast, and cervical cancer. She has also been training a number of healthcare personnel and promoting health and wellness in clinical settings. She is a researcher, a policymaker, and a policy implementer. Thank you for joining us, Dr. Singh. And last, but definitely not least, is my colleague, Dr. Stephanie Smith-Warner, who is also a faculty member in nutritional epidemiology at Harvard School of Public Health. She's an epidemiologist with 30 years of experience in conducting research on modifiable lifestyle factors and cancer incidence and survival. We are very much interested in hearing what she has to say about this. Main themes of her research have been determination of roles of plant foods, alcohol, dietary quality scores, and vitamin D on the development of cancer. Since 2002, she has served as a leader of the international consortium, the pooling project of prospective studies of diet and cancer. So she's one of the leading experts in the world on diet and cancer. So we have three wonderful speakers who can shed light on this very important topic. First, let me welcome each of you for participating in this webinar. We are very grateful to you. So I will go ahead and start. Maybe I can, as I call on you, maybe you can let me know if I have done justice to your absolutely amazing track record. And if you want to add anything else that is relevant about your work, feel free to do so. You can start with that. But let me go to Dr. Eliassen first. Heather, what is the evidence on diet and cancer? Obviously, in the scientific community, there is a lot of conversation, thousands of publications. But from a public communication perspective, it's so confusing. Depending upon what you read, what paper you read, or what program you watch, or what social media post you are exposed to, We get all kinds of information about this connection and the link between diet and cancer. So, can you tell us a little bit about the evidence relating diet or dietary patterns and cancer risk, and where are the most strongest protective effects? Where are the highest risks? Can we start there? So.
Sure. Thanks, Vish. Well, thanks very much for the kind introduction, and I'm happy to be here today to share a conversation with you. Um, so, as Vish mentioned, I oversee these large cohort studies, and just to give a little context in how we do nutritional epidemiology in cohort studies, we have collected information about diet and lifestyle throughout the past 50 years in our original Nurses' Health study. And we get a pretty good sense of women's diet, and it's collected repeatedly over time. So, across the life course, we can understand how people fall into one dietary pattern or another. And we follow these participants for um, disease outcomes and their healthy longevity. So as people develop cancer, we can then sort of go back in time and understand what their diets were like prior to developing cancer and compare that the diets to women who and men who did not go on to develop cancer. So in this way, we've been able to explore a lot about different dietary patterns, different dietary factors, and foods and nutrients, and begin to build evidence to understand the relationship between diet and cancer. So, what we found is, in general, um, diets that are rich in healthful plant-based foods with a variety of fruits and vegetables and whole food, whole grain intake tend to be associated with a lower risk of cancer. And this we can see this for a number of individual cancers as well as looking at total cancers together. So thinking about breast cancer, which has the highest incidence in women in India as well as in the US, we can see that healthful plant-based diets and total fruits and vegetables, as well as some subcategories of fruits and vegetables, are associated with a lower risk of breast cancer and of other cancers as well. So one example of a dietary pattern that we look at is to look at plant-based diets. And then particularly the subset of healthy plant-based foods, where we see that people who have higher intakes of these healthier diets have a lower risk of developing cancer. Another dietary pattern which we've been really interested in most recently is a dietary pattern that has been developed through the Eat Lancet Commission to look at benefits for both human health and planetary health. So we call this the planetary health diet. And again, it is, has a lot of healthful plant-based foods, but it's also aimed to be flexible by region and adaptable across cultures as well. And we see people who adhere more strongly to this planetary health diet have a lower risk of cancer, as well as cardiovascular and cardiometabolic diseases too. And on the flip side, we can also understand unhealthful diets and dietary patterns through epidemiology. So we have a couple of diet scores that have looked at diet related to hyperinsulinemia or inflammation. So these are more empirically developed scores that reflect how diet is related to things we can measure in the blood related to either inflammation or hyperinsulinemia. So these are biological pathways that have been linked with cancer. And when we look at these dietary patterns, we can see that people who have higher intakes of these more harmful diets in hyperinsulinemia and inflammation have a higher risk of developing cancer. And then interestingly, we can also look at dietary patterns after a cancer diagnosis to understand whether and how diet impacts survival after a cancer diagnosis. And we're starting to see similar patterns where more healthful dietary patterns and factors related to diet after cancer diagnosis are associated with better survival. So this provides a little bit of, introduction in terms of what we can see with epidemiology and how diet relates to cancer.
Wonderful. Thank you, Heather. Before I jump to Dr. Singh, I wanted to just briefly give a one sentence definition of two technical terms you used. One is planetary health. What do you mean by planetary health? Number one. Number two, you said hyperinsulinemia, or diet connected with inflammation. Can you give an example? So if you can clarify those two, then I can jump to Dr. Singh next.
Sure, yeah. So the planetary health diet was developed thinking about how diet impacts human health, but then also the impact of growing food, providing food for humans has an impact on our planet. So the diet score is developed to reduce the impact of food and raising food on the planet. So both in terms of soil impact, water impact, and greenhouse gas production. So the diet score was developed to maximize both human health and planetary health. Um, and then the hyperinsulinemia, thinking about high insulin or reduced sensitivity to insulin, which helps us process food and turn it into usable energy. If people have high insulin or are not very sensitive to insulin, this can lead to development of diabetes and cardiometabolic disease. And we also now know that it's related to developing cancer too. And inflammation, we can think about acute inflammation that can happen as a result of a wound, and your body is working to try to heal that wound. But systemic inflammation can also impact a variety of health outcomes, including cancer. And I think one thing that we can think about as a factor that contributes to both of these pathways is obesity. So that link between diet and cancer is also intertwined with obesity as well.
Wonderful. Thank you so much. I'll come back to a couple of those things. But Dr. Singh, you're not only a scientist, but also a scientific leader. You have been doing both leadership in the country around cancer-related issues. It sometimes makes me nervous whenever I say dietary patterns in India. We have 1.4 billion people with extensive differences regionally, including disparities as well as variation in diets. What do we know about different variations and disparities in diet and cancer itself in the country? What do we know, and where are the gaps in understanding, the evidence base, or even compiling the evidence and disseminating it?
So thank you very much for inviting me for this webinar, and it's a very important discussion in the prevention of cancer, so nutrition and obesity and diets. Yes, what you said, that India is a huge country of over 1.4 billion people, very diverse backgrounds, diverse ethnicity, geography, language, culture. And really no pattern can fit into that dietary pattern. Each culture has its own way of traditional way, and also they're transitioning to fast foods and modern diets. So still there's a pattern. And the data from our population-based cancer registries, 43 in number currently, they show this heterogeneity of different types of cancer. So we can see a pattern which is, say, the geographic variations, the regional variations in the patterns of cancers. But overall, in the country, oropharyngeal and lung cancer and prostate cancer are the commonest in men, whereas breast, cervical, and ovarian are the leading cancers in women. Coming to the heterogeneity in cancers, you can see a distinct pattern that in the northeastern part of the country and the eastern part of the country, and the states like Uttar Pradesh, Bihar, and Madhya Pradesh, the central India, most of the tobacco users are found there. And this we have demonstrated through our district level data collection and seen that there's the highest, even up to 60, 70, 80% of prevalence use of oral chewing tobacco. And definitely the oropharyngeal cancers are the highest in this region. When it comes to cervical cancer, then most of the people in the women in the rural areas and the tribal areas where healthcare facilities are suboptimal and the screening is limited, so women present at the advanced stages of cancer with its attendant mortality. Further, there are surveys, the National Institute of Nutrition, ICMR Institute in Hyderabad, has documented what India eats. So the survey is titled that way. And it shows that, in the rural India, cereals and millets, they account for nearly 60% of the energy intake, while vegetables and fruits, they are very less than 6% or so. Whereas when you look at the urban areas and the more socio-demographically advanced states, you can see that the use of ultra-processed foods and processed foods and sugar-sweetened beverages, this is going up. So definitely these factors are driving the obesity epidemic, and the upwardly mobile, the well-to-do, socioeconomically well-placed families, they are seeing epidemic of obesity and overweight. So we have to see that there are regional patterns with this in cancer type, as well as we have to focus on the cultural aspects and the attendant risk factors in each geographic region to be able to shape and the prevention strategies and the treatment strategies. Thank you.
Wonderful. Thank you. I want to come back to a couple of issues you raised maybe in a few minutes here. Let me go to Dr. Smith-Warner. Stephanie, a couple of times, more than once in this conversation so far, we kept hearing the term obesity, ultra-processed foods, diet. What do we know about what is ultra-processed foods? What do we know about, you have studied diet and breast cancer and other things. What do we know about these things? What about ultra-processed foods first? Because that keeps coming up, and there is so much coverage around that in the media these days, including in the US. What do we mean by that, and what do we know about obesity, diet, and cancer?
Right. Thank you for inviting me. First, thank you for inviting me to be a part of this webinar and for the kind introduction. As you mentioned, I have been leading international consortium for over 20 years that includes studies like the one that Dr. Eliassen had mentioned. The Nurses' Health Study and Health Professionals Follow-up Study are part of that consortium, as well as studies in North America, Europe, Australia, Japan, and China. And we have received the participant level data from all of those cohorts, harmonize that data, and then we look at associations between various exposures, including measures of body fatness and cancer risk. And we have conducted several analyses on looking at body mass index in relation to cancer, as well as many other individual studies have done on their own. And obesity has been shown to be related to a higher risk of at least 13 cancers, including postmenopausal breast cancer, colorectal cancer, as well as others. And in the Diet and Cancer Pooling Project, we've looked at, as well as others, looked at associations with body mass index measured at ages 18 to 20, and also those measured in mid and later adulthood in relation to breast cancer risk. We found that body mass index in early adulthood, so that 18 to 20 year age range, was associated with a lower risk of both premenopausal and postmenopausal breast cancer. And then we found that body mass index in early adulthood or mid-adulthood was associated with a lower risk of premenopausal breast cancer. And then for postmenopausal breast cancer, there's actually an increased risk between body mass index in mid and later adulthood and postmenopausal breast cancer. So the associations can vary. And one of the advantages of the consortium is its large sample size. We have over 2 million participants in the study and about 40 cohorts. So we're able to look at population subgroups and evaluate whether there are differences in the associations observed. It also allowed us to look at whether there was an association with sustained weight loss, because one of the concerns is if people try to lose weight, many times they don't lose weight, and then you have weight cycling. And so what would be the impact of if somebody lost weight and then they maintained that weight? And we were able to do this in this setting because not many people lose weight and then maintain that weight over time. And we found that individuals who had sustained weight loss over a 10-year time span had a lower risk of breast cancer. So it is a potential mechanism as a way to try and reduce breast cancer risk on a population level.
Thank you. I want to focus on one thing just to demystify some of the popular myths, right, around diet. Diet as a conception of, losing or eating whatever fad that's in the papers of the day. So when you say sustained weight loss, what do you mean by that? And what is sustained? How do we define sustained?
Right. So from the study perspective, what we did is, because we were limited by the data that's been collected by the individual studies, we looked at body weight at the start of the study. And then there was most studies had a measure of body weight between 4 and 6 years later. And that was used to determine whether somebody had gained weight, stayed the same weight, or lost weight. Then we had another measure about 5 years later, and we were able to then look at whether the weight loss that occurred in that first 5-year period was maintained over that second 5-year period. And that's how we had defined sustained weight loss in that study.
Thank you. Thanks so much. Before we go on to the audience, webinar audience, if you have any questions, please feel free to put them in the Q&A box. I'll get them in a few minutes here from my team, and I'll be happy to ask the speakers those questions. I want to get back to this notion of culture, since diet is so closely related to culture. I know it's a very difficult term. Culture is so nebulous as a term, but it is indeed related to what we eat and what we don't eat. So, Dr. Singh, can we start with you? You more than once referred to culture and diet. What are how does that manifest in India? How does culture influence what we eat and don't eat in India?
So, culture, I would say that, we have largely vegetarian type of a meal in most parts of the country. In the coastal regions, close to the sea, agriculture evolved as a necessity, and the culture evolved around the riverbeds. So people started agriculture where they were close to the riverbeds, where irrigation facilities and water was available. Those regions, so India has diverse, I would say, climatic conditions. So those regions, we have arid and dry regions. So those regions actually grew a lot of millets because they require very little irrigation. Coastal regions had a lot of water, so there they had a lot of fish as well as rice eating. And in central India, the system of irrigation and the canal irrigation came during the time of the Mughals. who brought the irrigation canal system in the country. And that's how wheat cultivation started in the central part of India. So wherever the Mughal influence was there, those geographies, actually people started cultivating wheat. Now, in the northeastern part, again, rivers are there in plenty, so rice is the predominant. So is rice predominant in the south of India. Now, coming to the non-vegetarian diets, it is popular. It was not very popular earlier, but the necessity actually made it happen. And we have religious also connotations to the diet, where some sects of people do not consume vegetarian foods, whereas the others do consume. And so I would say largely this is the sort of culture which shapes the diets. And of course, each region has, like I would say in the south, they have a lot of rice eating along with tamarind and a lot of curd eating. So these kind of
You are on mute, Dr. Singh.
so they shape the food and dietary patterns.
Mm-hmm.
And yeah. Is that
okay?
Am I audible? Yeah.
No, go ahead. Were you about to say something? All right, all right. So these things come up. Stephanie, I want to go to you, then I want to go to Heather after this. Um, um, these different types of foods, if I may call them, whether it is curd or yogurt or calcium or something else, so Dr. Singh just highlighted the patterns and the complex patterns in a country like India, right? Depending on the region. What do we know about these specific foods? Sometimes it's so confusing, to someone will say, oh, take this supplement, that might reduce cancer, or take that, stay in the sun a lot, What do we know about these things, these sort of a micro topics or foci on cancer incidence and prevention? So.
Right. So there's been quite a bit of research on nutrients, including micronutrients, macronutrients. So macronutrients like fat, carbohydrates, protein, micronutrients such as vitamins, and cancer risk. And I think the guidelines are now shifting more towards recommending foods instead of focusing so much on the nutrients, because it's easier to translate them. So the World Cancer Research Fund has reviewed the vast amount of literature on nutrition and cancer and come up with several recommendations. And this is not quite getting at your question, but the recommendations are to eat a diet rich in whole grains, vegetables, fruits, and beans. Limit consumption of fast foods and other processed foods that are high in fat, starches, or sugar. Limit consumption of red and processed meat. Limit consumption of sugar-sweetened beverages, and limit alcohol consumption. So those are their overarching guidelines in terms of nutrition. They also have guidelines on be a healthy weight and be physically active. So, and what's missing here is smoking, but the World Cancer Research Fund is focused on nutrition, physical activity, and anthropometry. And so smoking is to avoid smoking is a cancer prevention message, but it's not related, obviously, to nutrition, physical activity, and smoking. In their guidelines, they recommend not using supplements for cancer prevention as an overall strategy, but that the work on supplements has been controversial in a way, because in populations where the participants are deficient in vitamins, then supplementation has been shown to be beneficial. But in other study, like clinical trials, where the population probably has more of a are meeting the recommendations, there has not been a benefit. And in some cases, there have also been shown to be adverse effects of supplementation. So the literature on supplementation has been a bit controversial.
Thank you for that. I want to go to Heather, just building on what Stephanie was saying, Heather. So we also hear a lot about different types of diets, right? Mediterranean diet is one example. It keeps popping up everywhere. Are these kinds? Some of them are fads. Some of them are actually scientifically well-established patterns. And you have done a lot of work around plant-based foods, and you have been tracking with an SSL study. What do we know about these plant-based foods, especially in India? There's as Dr. Singh pointed out, this vegetarian non-meat diets and there are meat-based diets. What do we know about that? So
Yeah, sure. So one of the things we've been able to look at in our cohorts is when we say plant-based diets, we typically don't mean strictly vegetarian. Our study populations eat a range of, sort of what proportion of their foods are plant-based versus animal-based. And we can see health benefits if people are further on the spectrum of having a bigger proportion of their foods come from plant-based foods. But to your point about how can we classify this and thinking about the ultra processed foods? A can of Coca-Cola is technically plant-based. But I think all of us would understand that that is not going to be a healthful recommendation for any chronic disease outcome. So, you can think of a Coke versus an apple. Those are both plant-based, but we have one that's a very unhealthful plant-based, one that's a healthful plant-based. And so, as you said, there are lots of different diets and dietary patterns that are, in the literature and in the popular press, from Mediterranean to plant-based diets and beyond. But I think a component that we see that is common across many of these diets where we see benefits with cancer prevention is a higher proportion of healthful plant-based foods. And thinking about sort of tying this to the question that Stephanie was answering on supplements, some of the work that we do, we can look at the impact of micronutrients, so the vitamins and minerals, and try to understand what aspects of the plant-based diets might be beneficial for cancer. So one of the things that I've studied is carotenoids, so alpha carotene, beta carotene, lutein, zeaxanthin. These are compounds that come from very colorful fruits and vegetables, and they act as antioxidants, both in the plant and in the human when we consume them. And we can do studies where we can see that with breast cancer, for instance, women who have higher levels of carotenoids that we can measure in their blood samples have a lower risk of developing breast cancer. In terms of translating those findings to public health and to cancer prevention on a population level, we are not going to recommend, taking supplements to get the carotenoid levels up. But we know that carotenoids come from a wide variety of colorful fruits and vegetables, and that's the kind of recommendation that we can make on a population level. And that's going to benefit cardiometabolic disease prevention, as well as cancer prevention. So that's a way where we can, dig into what we can understand biologically about the nutrients and micronutrients in the foods, but then in terms of translation on a population level, think more broader about diets, because, we don't eat things on a nutrient by nutrient basis. We eat, based on a dietary pattern.
Wonderful, thank you. I have many questions, but I should open up the questions for the audience. While my team is compiling those questions, I want to ask each of you a question, and then we'll go to the audience questions. And maybe if we have time, I want to come back to other questions I have. So we'll start with you, Dr. Singh. So if there is evidence gap or if there are evidence gaps on diet and cancer, we need to collect more data. We need to understand more, particularly from the context of India. What else do we need to know? What should we do uh, to compile and amass more evidence before we take policy steps or prevention steps?
Yeah. So I think we need that to integrate the dietary and cancer surveillance systems. Because right now we have different surveys collecting data on cancers, different surveys on nutrition and anthropometry. So all these kind of data need to be integrated so that it's not in working in silos, but you are linking the dietary exposures to cancer or NCD outcomes. And we need to really have cohort studies, large prospective cohort studies representing different regions, taking care of the socioeconomic strata, dietary patterns across these stratas. We should collect the biomarker specimens for analysis and follow these up like the nurses' health studies have done. We do have that kind of expertise for carrying out the survey because we regularly conduct the National Family Health Surveys and the National Nutrition Surveys. But the cancer registry data is a separate survey, and there's no mechanism where we can sort of take evidence from one survey and extrapolate to another or see a long-term follow-up. So definitely we need that biomarker integration into our dietary surveys. Apart from that, I think we need to have that capacity for analyzing these kind of data, like the what is the kind of products which are being sold in the market. So has their supply and demand has gone up over the years, and what are the people consuming over a period of years? So I was reading one study where they have shown that how the ultra processed foods marketing and their consumption has gone up, leading and giving evidence as to the rising obesity in Brazil. So I think something like this is needed for linking up the dietary patterns with NCDs and cancer.
I see.
Thank you.
Thank you. Heather, Stephanie, what else? I mean, you are in an enviable position of having these major cohort studies, having made significant contributions, including not just surveillance, but also with biomarkers. You had that advantage. What else do we need to know? What are the evidence gaps? So maybe Stephanie will start with you.
Sure. When I described the consortium that I'm leading, I had mentioned the continents and countries that are in that study, and India was not one of the countries that I mentioned. So there are regions of the world that are not represented in this international consortium, and so I echo what Dr. Singh said, is that having prospective studies in India to see if the associations that are being seen in other parts of the world, are they relevant to the population. You also might identify other potential lifestyle factors or modifiable factors that are associated with cancer. I think a big area that we don't know much about is early life exposures. It's challenging to gather that data in these cohort studies. So there are very few studies that have measures of diet or during adolescence or childhood, and those might be important windows of susceptibility for cancer. And so I think that having studies that have those measures will allow us to learn more about the cancer process. And then I think translational research, where you take the recommendations and figuring out how to implement them in different populations is really important. So we have, like I mentioned, the guidelines from the World Cancer Research Fund, but then being able to take those guidelines and implement them into populations successfully will be important.
Thank you. I'll come back to the translation in a second here. Heather, what do you think?
Yeah, I think both Dr. Singh and Dr. Smith-Warner made really good points. And just to carry on a little bit from that, thinking about the um, how can we implement change, as Stephanie had mentioned, and the fact of the thinking about diet in childhood, I think that is a really important potential window of susceptibility. It's also an opportunity to set, a life course of dietary habits as well. So, being able to implement Dr. Singh had mentioned, implementation on a family-based level is important. Integrating the impact of dietary change across an entire family, I think, can help set up, lifelong patterns in children that could have impact going forward. And then on the other end of the spectrum, I think an area that is of great interest of mine, and I think we need more information, is how modifiable factors after a cancer diagnosis could impact survival. I think we see some hints that obesity, physical activity, and diet are playing a role, and I think we need more information on, what factors can be changed that can improve survival after a cancer diagnosis. Stephanie had mentioned the World Cancer Research Fund guidelines, which are really built on evidence based on cancer prevention, and they're also recommended for cancer survival, but the evidence is not very large there.
Mhm. Wonderful. Thank you. So let's go to the audience questions. There's one question that keeps coming up, which is very germane to our conversations, the discourse around climate change. And the question is, climate change is affecting crop patterns widely and would be altering nutritional status for different regions. In fact, I think this is a concern that has come up, how in addition to migration and other issues, climate change could potentially influence dietary patterns and the consequences we are likely to see. So I'm just curious, I'll start with you, Heather, because you started talking about planetary health, and then I want to go to Dr. Singh and Stephanie to see if they have any response to that. So.
Yeah, so as I had mentioned, the planetary health diet, I think one example of thinking about foods and diet where we can see an impact on both the planet and human health is thinking about meat intake. So, raising animals for meat consumption is incredibly impactful on our planet, and is not great for human health in terms of, increasing risk of both cardiometabolic diseases as well as cancer. So, this is an area where raising cows for meat consumption has a really big impact on the soil health as well as greenhouse gases. And so that's a place where we could think about, can we make changes and reduce the consumption of meat that would benefit both the planet and human health. I think the question about the impact on soil and the quality and nutrient content of fruits and vegetables that are grown in such soil. I think that's an area that would be interesting to better understand the impact on nutrient level. However, even good healthful vegetables that are grown in poor soil are going to have a benefit. So we shouldn't be disregarding vegetables just because they're grown in soil that may not be as replete, but certainly an area of interest as well.
Thank you. Before I go to Dr. Singh with a very specific question, Stephanie, do you want to add anything to that?
I was just going to say, from a research perspective now, there's an interest in looking at substitution analysis. So if you, piggybacking off of what Dr. Eliassen said, if you substitute red meat consumption with nut consumption, what what impact do you see on the outcome of interest that you're looking at? And so then that's another way. It's not directly answering your question, but it's another way to look at the impact of these types of changes on health risk.
Great, thank you. Dr.
Yeah.
Singh, there's a very...
I'd like to add on, I'd like to carry on
please go
forward
ahead.
from
Yes.
what the previous speakers have said, that, largely diets earlier, maybe 100, 200 years ago, whatever we ate was for the sake of nutrition, or we were feeling hungry, and just to take care of our health in a regular way. But now what we eat is mostly for feasting, celebration. And those are the kinds of through advertisement industry. They are aspirational foods, and they think that it's upwardly mobile. So that celebration is going on, feasting is going on all the time. And in my opinion, I was reading one very important editorial in this context in the Lancet of 18th November this year, which says that you should support locally sourced, affordable, minimally processed, convenient meals which appeal to the consumer. And all this is going to sort of be helpful in the planetary health, as well as the One Health approach to human health, animal health, and environmental health. And for one, I would also like to say that tobacco and such plants, they really very damaging for the soil health. And besides, of course, taking away the nutrient from the soil, and they also prevent the insects growth, the normal insects growth in that region. So they really impoverish the soil. Apart from that, both wheat and paddy are very highly intensive in the requirement of their water. So we should grow millets instead, which require less water. So in that sense, the planetary health can also be climatic change, and planetary health can also be addressed. Yeah. Go
Well
on,
said.
please. You have wanted to ask
No.
something, Preston, before I... Yeah.
No, that was very helpful. Thank you for adding those remarks. I appreciate it. There are questions that come up in terms of disparities in India. So you can get the best treatment for cancer or heart disease in India if you have the money. We have some of the, you have some of the best doctors, you have best hospitals, there is medical tourism. But there are also tremendous gaps. A lot of people may not have access to those services and those doctors, etc. So when we talk about plant-based foods, increasing consumption of fruits and vegetables, and different types of diets that are conducive to cancer prevention, one has to ask, about the socioeconomic status of the audiences in India and how different groups can afford different things. Do you want to say a little bit about those disparities in India when we make these recommendations?
I think modification of our food environments necessarily has to come from the affordability. Like you see these ultra processed foods or these packaged foods, they are considerably convenient to use, they less time, and they're very affordable. So definitely, if we want to revitalize our traditional dietary patterns, we have to pay a lot of importance, and this would involve intersectoral coordination, not just from the agricultural sector, but also from the revenue sector, the transport, and so on and so forth, and also the appeal to the consumers. I think that's something, health communication or nutrition literacy, as you may call it. So definitely it will affect these. But if you go on to the rural areas where this fast food or the ready-to-eat foods has not reached to that extent, and they live in joint families, they still consume homemade, home-cooked food, though the transition to refined grains is going on over there as well. Does that answer some of your questions?
Yeah, thank you. That's very helpful. I think that is the challenge, I think, particularly with the increasing urbanization, the convenience of ultra processed foods. Even in India, it's surprising how much it is consumed. So we are coming to the end. I have at least 35 more questions from the audience. I have so many questions, a full page of them here. Obviously, we cannot do justice to this. We need more than an hour for this. But before we end, I want to give you each a 1 minute, no more than a minute, to make any closing remarks, from the context of India and evidence, particularly translating what we have said. Maybe we'll start with you, Stephanie. I know I'm calling on you first, so just 1 minute final remarks, so.
Okay. I think that what's important, it kind of echoes what I said earlier, is having the research, like prospective research that is looking at associations between nutritional factors and cancer risk in India, and trying to look maybe across the life course to try and understand those associations better, with inclusion of, if it's possible, work that could look at mechanisms. And then the other piece would be translational research, which so you could take, given that take what's currently known, how to translate that into the India population, with being mindful of not trying to increase disparities that might already exist. So having to take that into account in terms of the implementation.
Thank you. Heather?
Yeah, great. I think piggybacking on Stephanie's important points, the other piece to think about is how, these diet and lifestyle changes are hard to achieve. And so thinking about policy perspectives that can help support any shift on a population level, I think are incredibly helpful. So just as Dr. Singh was talking about focusing on interventions at a family-based level, trying to, understand what policy implications or what policies may help support sustained changes in diet and lifestyle, so that we can all achieve, benefits for chronic disease health more broadly, I think would be really important to understand.
Thank you. Dr. Singh?
Yes. So I think my best bet would lie with the school-going children. If we can de-glamorize the fast food, ultra-processed foods, and such kind of foods from to the children, and take the parents into confidence, and the teachers as well, I think then we can see a ray of hope where so we must, as academicians, as researchers, as scientists, we must go out to the schools and give talks and lectures like we've been doing at ICPR. Our scientists do go out and meet the students, call the students over, and they are really surprised and about the the opinion that we give them, and they understand that these are the myths and the misconceptions which the advertisement and media industry and the fast food industry has planted. And so I think this is the best bet, and with a strong political commitment, and policy needs to be with us for implementation. And as has been pointed out by Heather a couple of times, that we would like to focus on family-based interventions, because somebody or the other in their family is suffering either from obesity or from diabetes or from hypertension, and the treatment lies in just their own kitchen, which is the, if I may call, the pharmacy, in another terms, FARMCY rather than FPH pharmacy.
Yeah.
So yeah, so I think that would be the message from my side. And our Prime Minister also has committed to reducing obesity and reduction in the cooking oil consumption. So with that kind of political commitment, I think we can have some hope for the future. Yes.
Right. Evidently, this is a conversation that can go on for at least another 2 hours, given the importance and the complexity of the topic. We are out of time. My apologies to the audience members whose questions I could not ask. There are many questions here. But I do want to highlight the fact that all our speakers have raised the importance of both social determinants of health as well as communication and commercial determinants that play a significant role at a population level and the evidence for it. Stephanie, Heather, Dr. Singh, please accept my gratitude. Thank you so much for taking the time. I know it's very early in the morning for us here in Boston, and it's quite late in the evening for you in Delhi, in India, and in other parts of the world. So thank you for taking the time. Absolutely amazing. We should bring you back and have you answer more other questions that we have. But thanks for taking the time, and thank you for all that you do in terms of science and science policy. I also want to thank the audience who have joined us on the Zoom webinar. Thank you again. We'll continue to hold these webinars. Please go to our website of Harvard Chan India Research Center. This video has been recorded, so it will be available there. And other programs are on the annual. And finally, I also want to thank my team who are patient and diligently working behind the scenes to hold this webinar. Thank you, everyone. Thanks so much. Bye.